Hello, and welcome to my series on the CT of thoracoabdominal emergencies. I'm Dr. Benjamin Strong, the Chief Medical Officer of Virtual Radiologic, or vRad. I started my career with an internal medicine residency and followed that with 3 years of work as an emergency physician. I then returned to training for a radiology residency and a fellowship in body and MSK MRI. In the course of my over 20 years in radiology, I have worked as a private practice radiologist, an academic radiologist, and for the last 17 years as a teleradiologist for vRad. I have been the chief medical officer there for 8 years and am licensed to practice in all 50 states. Here is our agenda for this series, which I have broken into 9 sessions of 8 cases each, all grouped by organ system. Session 3, Emergencies of the Proximal Gastrointestinal Tract. We'll begin with a case of Candidal Esophagitis. This hypodense wall thickening of the esophagus is, of course, nonspecific, but the extent is impressive. From the very proximal to the very distal esophagus, everything shows that wall thickening. When I see that extent of esophagitis, I think of Candidal esophagitis as well as perhaps a few other infectious causes, such as CMV, especially in these immunocompromised patients. So that is a case of Candidal esophagitis. Our next case is of esophageal rupture, Borehome syndrome. This results from continued retching and is frequent in alcoholics as a complication of Mallory-Weiss tears. There is mediastinal gas throughout the mediastinum, not confined as is frequently seen in traumatic esophageal rupture. In these Borehome syndrome cases, the mediastinal gas tends to be really quite free roaming. Soft tissue windows also show the mediastinal gas and show the contrast material leaking from the esophagus, not something you get to see with every esophageal rupture. And here we'll see that contrast leak through a defect in the left lateral esophageal wall. Again, not the kind of thing typically seen in all esophageal ruptures. And here the pneumomediastinum, again, free-flowing throughout the mediastinum instead of restricted to the region of rupture as is frequently seen in traumas. So that is a case of esophageal rupture, a Borehome syndrome due to persistent retching. Our next case is a gastricvolvulus. This is of the mesenteroaxial or mesoaxial type, where and this is the important point, the duodenum lies above the gastroesophageal junction. So here it is lying above the GE junction, and that is the critical thing that allows you to diagnose the mesoaxial type of gastricvolvulus. The stomach is obviously obstructed and markedly distended. And you can see the nasogastric tube in the esophagus, which really allows you to track the anatomy here on the cine. This is known as Borchardt triad, that of retching, epigastric pain, and inability to pass a nasogastric tube. Obviously, it was possible here, but that's a common complication of gastricvolvulus is the inability to pass a tube. So here again, we see gastric distension. And look at the displacement of the spleen, clearly showing that the stomach has essentially pivoted on its axis. And there is that displaced duodenum located above the gastroesophageal junction and the wandering spleen displaced due to the twisting of the stomach. There again is the duodenal displacement and the wandering spleen. Here on the coronals, you can see the same findings. The antrum and duodenum pass above the GE junction, and there again is the spleen displaced medially and inferiorly. So that is a case of mesenteroaxial gastric volvulus. Our next case is of alcoholic gastritis. Of course, there is steatosis of the liver, which helps in the diagnosis here, but extensive hypodense thickening of all the gastric folds, really a striking degree, and impressive on the cine as well when you see the extent. Well, they always say in teleradiology that we lack for clinical history, but in this case, I know exactly what happened. This patient had 7 shots of Jack Daniels in the course of an hour, and this is the resultant alcoholic gastritis. Our next case is a perforated posterior gastric ulcer. There's a good deal of free intraperitoneal gas and fluid on these upper images as well as on lower images, smaller foci of gas and more fluid here. But most importantly, there are gas collections within the lesser sac lying anterior to the pancreas and behind the posterior wall of the stomach. The lesser sac can only be accessed by intraperitoneal gas if it passes through the posterior wall of the stomach. This is essentially pathognomonic for a posterior gastric ulcer with perforation. Of course, all throughout the abdomen in cases of gastric rupture, you'll frequently see significant small bowel wall thickening for obvious reasons. So here we have the free intraperitoneal gas collections. They're in the portal region as well. But here are the most important ones, those in the lesser sac, again, diagnostic of a posterior gastric ulcer perforation. So that's, again, a perforated posterior gastric ulcer. Our next case is a duodenal ulcer with perforation, presenting as pancreatitis. This is a frequently described, but in my experience, not so frequently seen complication of a duodenal ulcer, and this is a nice example of it. There's extensive peripancreatic stranding, clearly consistent with pancreatitis, and it might be easy to miss this small focus of extraluminal gas in the retroperitoneum and simply call this primary pancreatitis. But there, that focus of gas with fluid lying right behind the second and third portions of the duodenum, pretty characteristic for a perforated ulcer. So here again is the peripancreatic stranding, but the critical finding of extraluminal gas here adjacent to the second portion of the duodenum. So that is a perforated duodenal ulcer with resultant pancreatitis. Our next case is an annular pancreas causing partial obstruction and ultimately ulceration with pseudoaneurysm formation. Here you see the circumferential pancreatic tissue surrounding the second portion of the duodenum, pretty typical location, usually actually fairly proximal in the second portion of the duodenum. You can see extensive stranding fluid throughout this complex, and there within the wall of the anterior second portion of the duodenum is a well-circumscribed contrast collection clearly representing a pseudoaneurysm. You can see the oral contrast filling the lumen immediately posterior to that collection. And let's look on the cine. Again here first, the partial obstruction in the circumferential pancreatic tissue, and then the pseudoaneurysm in the wall of the duodenum. Most likely, this partial obstruction of the second portion of the duodenum causes disproportionate exposure to unneutralized acid there in the mucosa of the second portion. So that most likely led to an erosion and ulceration and formation of a pseudoaneurysm. So that's an unusually complex presentation of an annular pancreas. Our next case is my favorite case of gallstone ileus. You see this begins with both pneumomediastinum and a small left pneumothorax. This patient presented with retching or persistent non-productive vomiting, and that ultimately resulted in an esophageal perforation and a small pneumo. You can appreciate that surrounding the distal esophagus, and again the small pneumothorax. All right, we'll move on to soft tissue windows. You can see the central arborizing gas consistent with pneumobilia. Lower down, you can see the decompressed gallbladder with a tiny focus of gas in its fundus. The gallbladder is, in all these cases, completely decompressed, as one would expect with the size of the fistula that forms between the gallbladder and duodenum, which you can just appreciate the lower aspect of on this cut. Lower down, you can see extensive hypodense thickening of the third portion of the duodenal wall, and obviously the cause of all the trouble, this large gallstone hung up at the ligament of Treitz. This is a fairly common location for gallstone ileus to cause obstruction. In fact, it is the second most common, second to ileocecal region. So let's look at this video. First, the pneumobilia, which you can track there to the portal region. Now the decompressed gallbladder and its communication to the duodenum can be very nicely seen there. And there's the fundus. Lastly, the wall thickening, and obviously the large gallstone causing the obstruction. Here we have on the coronal the pneumobilia, and there the gallbladder with that communication to the duodenum, and of course the gallstone. We'll let that one run one more time. There's the pneumobilia, the decompressed gallbladder with fistula, and the wall thickening and gallstone. So that is a case of gallstone ileus with bowel obstruction at the ligament of Treitz. And that concludes Session 3, Emergencies of the Proximal Bowel. Thanks for watching.